Welcome to the deep dive. So today we have a really highly specific mission.
Yeah, we're getting right into it.
Exactly. We're drawing directly from, the 2024 clinical guidelines, the ISRCTN registry, and some really recent Frontiers case studies. And we're looking at a crucial question for you, the listener. Like, what do you actually do when the gold standard treatment for lichen sclerosus just completely fails?
Which is a terrifying prospect for patients, honestly.
It really is.
Mm.
So specifically, we want to know, can systemic immunosuppressants, like a drug called methotrexate, can they be effectively used for these really severe refractory cases?
Right, because we are looking at a chronic lymphocyte-mediated inflammatory skin condition here. And when it escapes control, it's devastating.
Yeah, the physical toll is just immense.
It is. You've got intense pruritus, which is just agonizing itching, the pain, and those characteristic porcelain white atrophic patches. And they primarily show up in the anogenital region.
Which obviously completely alters a patient's quality of life.
Exactly. And if that underlying inflammation isn't controlled, the architectural distortion of the tissue, it becomes permanent. Not to mention, there's a very real documented increase in the risk of developing squamous cell carcinoma.
Right. So controlling the inflammation is just paramount. It's not just about symptom relief, as important as that is, but it's for structural preservation.
Yeah. You have to stop the damage before it sets in.
And for a significant portion of patients, the standard protocol does work. But we're really tailoring this deep dive specifically for the edge cases, for you, or maybe someone you love who has just hit a wall.
Yeah, those tough cases.
But to understand the need for, a systemic intervention, I feel like we first have to establish the baseline of that standard care, which relies really heavily on ultra-potent topical corticosteroids.
Yeah.
Like clobetasol propanate.
Right. And the clinical guidelines from both the British Association of Dermatologists and the European forums, they are absolutely unequivocal on this. Clobetasol is the first-line defense.
No question about it.
None. Because LS is driven by this localized hyperactive immune response. So applying an ultra-potent steroid directly to the affected tissue, it forces this massive downregulation of pro-inflammatory cytokines, right at the site of the attack.
I always think of it like using a highly effective fire extinguisher on a kitchen stove,
That's a great analogy, actually.
Yeah, like you're aiming a concentrated burst of suppression directly at the flare-up, but you're not flooding the entire house with water.
Exactly. And I know you probably saw in the guidelines, if clobetasol induces skin atrophy or if it's otherwise contraindicated, they deploy topical calcineurin inhibitors, or TCIs.
The tacrolimus, right. So that's essentially the backup fire extinguisher.
Yeah, exactly. TCIs are great because they bypass the glucocorticoid receptors entirely. They inhibit calcineurin, which then blocks the activation of T cells and the transcription of inflammatory cytokines.
So they still get that local immunosuppression.
Right, but they avoid the specific thinning of the epidermis that you get with, long-term steroid application.
Okay, so the localized toolkit is solid. But our core focus today is on what happens when the fire extinguisher just isn't enough.
Yeah, when the fire spreads.
Exactly.
Yeah.
And the sources highlight two primary scenarios where patients hit that wall. The first is refractory lichen sclerosus, where despite strict adherence to these ultra-potent topicals, the disease just continues to progress.
Basically, the localized inflammation simply outpaces the localized suppression.
Right. And then the second scenario is generalized extragenital lichen sclerosus.
Yeah, this is where things get incredibly difficult to manage because the sclerosis and the atrophic patches, they disseminate way beyond the anogenital region.
They start showing up everywhere, right?
Yeah, presenting across the trunk, the limbs, the chest, the back.
And obviously, treating that topically just becomes physically and medically unviable. Like, if a patient has active lesions covering, say, 30 or 40% of their body surface area.
Good luck trying to meticulously apply a thin layer of clobetasol to every single plaque. It's just impossible.
Right. And even if you could, applying ultra-potent steroids over that vast of a surface area, you're introducing severe risks of systemic absorption anyway.
Which forces a total pivot in the treatment paradigm. You can't treat from the outside in anymore.
You have to treat the immune system from the inside out.
Exactly. This is the exact clinical threshold where systemic immunosuppression becomes, a necessary consideration to halt the disease progression.
Which brings us right to the core question we promised to answer. Can we use systemic immunosuppressants, specifically methotrexate, for these severe, generalized, or refractory cases?
And looking at the literature, the answer is a very strong yes.
Yeah, methotrexate is cited frequently across the guidelines as a primary systemic option.
It really is. And if we look closely at how dermatologists deploy it in these scenarios, the regimen is usually oral, low-dose methotrexate.
Low dose being the key word there.
Right. Typically just 10 to 15 milligrams administered once a week. Because, in oncology, methotrexate is used at massive doses to block DNA synthesis.
Right, as a chemotherapy agent.
Exactly. But in these low dermatological doses, its whole mechanism of action shifts. It promotes the release of adenosine, which is this really potent endogenous anti-inflammatory agent.
Okay.
So it's essentially dampening the overall T-cell mediated response across the entire system.
Wow, okay. And I saw in the 2023 Frontiers update that for the absolute most aggressive generalized cases, specialists don't even just rely on the oral methotrexate alone.
No, they often double down.
Yeah, they combine it with pulsed, high-dose intravenous corticosteroids,
Yeah.
like methylprednisolone,
Oh, yeah. Administered over 3 consecutive days every month.
which sounds intense.
It is, but bringing in pulsed IV steroids acts as a rapid induction therapy. It aggressively knocks down the acute inflammatory cascade right away.
Getting them some immediate symptomatic relief.
Exactly, because the methotrexate, it can actually take weeks to reach steady-state efficacy. So the IV steroids bridge that gap while the methotrexate builds up in the system for long-term maintenance.
And the clinical outcomes for this combo approach are striking. The studies show clinical improvement, or like a significant decrease in severity scores, in roughly 75 to 85.7% of these previously recalcitrant cases.
Which is huge. Achieving over an 80% response rate in patients who have already failed the gold standard, that's a massive clinical victory.
It is. It absolutely is. But, I mean, I have to play devil's advocate here and push back on the safety profile, because methotrexate is not benign.
No, not at all.
We are talking about a drug that carries a really significant systemic burden.
The adverse effect profile is substantial and is completely non-negotiable when discussing systemic therapy. You have to address it.
What are patients usually dealing with?
Well, patients frequently battle debilitating fatigue, severe nausea, and headaches. And because it does affect rapidly dividing cells to some extent, alopecia or hair loss is a documented risk.
Right. But clinically, the primary concerns are deeper than that, right?
Yes. The major clinical concerns are hepatotoxicity, so liver damage, and bone marrow suppression.
Yeah, the BSH guidelines, the British Association for Sexual Health and HIV, they are incredibly strict about this. They explicitly mandate that these therapies are toxic and require rigorous blood monitoring.
You're not just handing over a prescription and saying, see you in 6 months?
No, exactly.
Oh.
Patients need constant evaluations, liver enzymes, comprehensive metabolic panels, complete blood counts to ensure their bone marrow isn't crashing.
Which means it necessitates management within a specialized dermatology clinic. The prescribing physician has to constantly balance the efficacy of the immune suppression against this creeping stress on the hepatic and renal systems.
It's a tightrope walk, because if liver enzymes spike, the dose has to be titrated down or paused, right?
Right, and then you risk a massive flare of the lichen sclerosus.
So given those hepatotoxic risks, like if methotrexate is strictly contraindicated for a specific patient, we need to look at the rest of the systemic toolkit. And the European guidelines prominently feature the off-label use of oral retinoids.
It's like acitretin. Yeah.
How does that compare?
Well, acitretin operates on a completely different axis. Rather than broadly suppressing T cells, oral retinoids modulate keratinocyte proliferation and differentiation.
So they're targeting the skin cell turnover itself.
Exactly. So they're uniquely effective for patients presenting with severe hyperkeratotic lichen sclerosus, where the primary issue is this profound thickening and scaling of the epidermis.
But there's a massive caveat with acitretin, right? Its extreme teratogenic profile.
It causes severe birth defects.
Yeah. The European guidelines explicitly state that pregnancy must be avoided for at least 2 years after a patient stops taking the medication.
2 years, which is just wild.
Because of its long half-life and fat storage.
Right.
Right. So that completely removes it from the table for any younger patient or, frankly, anyone with childbearing potential.
Which leaves us with the broader systemic immunosuppressants, the ones heavily borrowed from the transplant and rheumatology worlds.
Like cyclosporin.
Right. Cyclosporin is a calcineurin inhibitor. It's actually similar to topical tacrolimus, but obviously it's systemic. It binds to cyclophilin, profoundly blunting the activation of T lymphocytes.
But it has a notorious reputation for inducing nephrotoxicity and hypertension.
Kidney damage and high blood pressure. Yeah, it's rough.
I also noted mycophenolate, mofetil MMF, and hydroxychloroquine in the literature.
Yeah, MMF inhibits an enzyme that's crucial for purine synthesis in T and B cells,
Yeah.
and hydroxychloroquine alters the pH of lysosomes, which interferes with antigen processing.
So every single one of these drugs offers a different mechanism to stall the immune system,
True.
but they all just demand such a heavy physiological toll on the body.
They do. And this brings us to, honestly, the most frustrating reality of treating refractory LS. When you analyze the major clinical guidelines, this stark phrase just repeats itself over and over.
No consensus and little evidence base.
Yes, it's glaring.
The grading of the medical evidence for these systemic agents is concerningly low. Almost all the recommendations for methotrexate, cyclosporine, or MMF, they're sitting at grade 3, level D.
Which, in plain terms, means the guidelines are built almost entirely on small, retrospective case series, or just the aggregated expert opinions of specialists.
Right. We lack those large-scale, double-blind, placebo-controlled, randomized clinical trials.
Exactly. So for decades, a dermatologist facing a generalized case has had to rely on, well, anecdotal success rather than high-fidelity comparative data.
But that's changing, right?
Yeah.
The ISRCTN registry offers a massive shift in that landscape. There is actually an ongoing, active clinical trial designed to finally close this evidence gap.
It's so exciting. They're actively randomizing patients to evaluate these exact drugs head-to-head.
And the trial design is exactly what the field requires. Like they're taking patients with severe LS and assigning them to receive either methotrexate, MMF, or hydroxychloroquine.
And then comparing the efficacy and toxicity profiles directly against a control group receiving standard topical clobetasol.
Right. And each treatment arm is monitored over a 6-month period. So once that data is aggregated and published, specialists are finally going to have the hard comparative statistics they need.
Yes, to choose a systemic agent based on empirical superiority rather than just relying on, educated extrapolation from other autoimmune diseases like psoriasis or rheumatoid arthritis.
Having that definitive data is going to completely optimize patient safety and streamline the pathway to remission. But, even with better data, we are still utilizing broad immunosuppressants.
Which goes back to your analogy earlier.
Right. If a topical steroid is a fire extinguisher, drugs like methotrexate or MMF, they act like a building-wide sprinkler system.
A very messy sprinkler system.
Exactly. They successfully put out the fire in the kitchen, but they flood the basement, they ruin the drywall, and they cause immense collateral damage across the body's systems.
Nausea, liver strain, bone marrow suppression.
Yeah. So getting away from that collateral damage requires a much deeper understanding of the pathophysiology of lichen sclerosus at a cellular level.
We have to identify the specific molecular pathways driving the disease, rather than just bludgeoning the entire immune system into submission.
And the sources actually outline this pathophysiology really clearly. The inflammatory infiltrate in LS is overwhelmingly driven by a Th1 type immune response.
Right, with a heavy reliance on a specific signaling cytokine called interferon gamma.
Interferon gamma. So it acts as the primary messenger. But for that messenger to actually initiate the inflammatory cascade within the skin cells, it has to transmit its signal through a highly specialized intracellular communication network.
The JAG-STAT pathway.
Yes, exactly. So if the overactive immune system is, say, a general broadcasting the command to attack the vulvar or extragenital tissue, the JAG-STAT pathway is the specific radio frequency they are using.
I love that. And historically, our systemic drugs, the methotrexates of the world, they just blew up the entire radio tower,
leaving the patient exhausted and sick.
But the advent of JAK inhibitors allows us to simply jam the specific frequency.
The sniper approach.
Exactly. These are targeted small molecule therapies. They selectively bind to and inhibit the Janus kinases, the JAK enzymes.
Effectively neutralizing that interferon gamma signal.
And stopping the inflammation at its source without inducing the broad cytopenias or hepatotoxicity associated with those legacy immunosuppressants.
Which brings us to the 2024 paper published in the journal Frontiers in Immunology. They provided this incredibly detailed breakthrough case study demonstrating this exact mechanism in action.
Oh, this case study is incredible. They chronicled a 62-year-old woman suffering from a 2-year history of refractory generalized lichen sclerosus.
She presented with extensive atrophic patches, plaques, and severe sclerosis, spanning her trunk, limbs, and vulva.
She had entirely failed conventional therapies, including prolonged courses of ultrapotent topicals, and her pruritus, the itching, was measured at a 9 out of 10 on the visual analog scale.
A 9 out of 10, wow.
Living with a constant 9 out of 10 itch accompanied by spreading sclerosis is physically and psychologically agonizing.
Unimaginable, honestly. So because she was refractory to standard care, The clinical team initiated treatment with upadacitinib, which is a highly selective JAK1 inhibitor dosed at 15 milligrams daily.
And the pharmacokinetic response was remarkably fast. Within 4 weeks of initiating the daily oral therapy, her pruritus VAS score dropped from a 9 down to a 1.
Down to a 1 in just 4 weeks. That is a near complete cessation of the defining symptom.
It's basically unheard of with older therapies.
And by her 10-month follow-up, the pruritus score was a 0. The sclerosus and atrophic patches demonstrated marked clinical improvement, and she developed no new lesions.
And, just as importantly, her routine laboratory monitoring remained entirely unremarkable.
So no organ damage.
None. Her hepatic panels, lipid profiles, complete blood counts, they showed none of the derangements we would typically expect after 10 months on a systemic agent like methotrexate or cyclosporine.
So she received this highly targeted, convenient daily pill that provided rapid, sustained remission, and without the collateral water damage of the sprinkler system. So the obvious question for anyone listening is, well, why aren't JK inhibitors immediately replacing methotrexate as the go-to systemic option?
Yeah, and the limitation lies entirely in the maturity of the data. Upadacitinib, along with other JK inhibitors like baricitinib and cafacitinib, they represent a monumental paradigm shift in dermatology. But currently, their efficacy in lichen sclerosus is documented only in these isolated case reports and minuscule sample sizes.
Ah, right. We need the phase 3 trials.
Exactly. We need the same large-scale, randomized controlled studies that the ISRCTN registry is currently running for the older drugs. We need those applied to the JAK inhibitors.
To establish long-term safety, optimal dosing protocols, and, to watch for latent adverse events.
Right, because until those comprehensive data sets are published, JK inhibitors will unfortunately remain an off-label, highly experimental option.
Reserved for the absolute most severe recalcitrant cases where all other systemic avenues have just been exhausted.
Precisely.
So let's kind of synthesize this landscape for you. The mission today was to determine if systemic immunosuppressants can be effectively deployed for severe refractory lichen sclerosus. And the clinical literature confirms that yes, drugs like methotrexate, MMF, and oral retinoids, they offer a vital lifeline when the localized fire extinguisher of clobetasol fails.
They carry a heavy toxicological burden, obviously, and require rigorous specialist monitoring, but they are highly effective at halting the spread of generalized disease.
And simultaneously, we are watching the dawn of precision medicine in this space. Targeted therapies like JK inhibitors prove that we can isolate and neutralize the specific inflammatory pathways of LS, offering rapid symptom relief with a fraction of the traditional systemic toxicity.
It's an incredibly hopeful time for research.
It really is. The ultimate takeaway is one of therapeutic agency. If you or someone you love is suffering through a refractory case and you're applying creams that no longer work, you are not out of options.
Not at all.
The medical toolkit extends far beyond topical steroids. And consulting with a dermatologist about escalating to these systemic or targeted therapies, it could fundamentally alter the trajectory of the disease.
And, we've spent this whole time discussing how to suppress the active immune response, right? Whether broadly or precisely.
Right.
But looking at the cutting edge of dermatological research, there is another frontier entirely. Researchers are now investigating the role of tissue-resident memory T cells. These are the specific immune cells that embed themselves in the skin and literally remember the lichen sclerosus.
Wait, they remember it?
Yeah, they cause those localized flare-ups even years after systemic treatment has been withdrawn. So could the next evolution of treatment not be suppressing the active attack, but rather finding a way to erase that cellular memory entirely from the tissue?
Erasing the memory of the disease itself. Wow. That is definitely something to mull over.
Right.
Well, thank you for joining us in this deep dive. Until next time.